Hi everyone, today let's review the markings of a recent left and complete cleft lip repair. This patient did not require pre-surgical lip or nose molding, for the lip segments were close together and the nasal deformity was not severe. There is a nasal deformity, however, of the septum and alar base even in these more mild cases. Here's the oral commissures being marked, and this helps set Nordhoff's point and the red line. You need to accurately reapproximate the wet and dry vermilion, for if the wet vermilion ends up aligned to the dry, it will end up in chronic crusting to the upper lip. Now, I spent a lot of time marking the white roll, both the vermilion cutaneous junction and the superior portion of the white roll on both the medial and lateral lip elements. I find that marking this entire cascade of the white roll helps me to best locate and determine Cupid's bow peak and trough on the medial lip and Nordhoff's point on the lateral lip. Here I'm looking at the philtral column on the non-cleft side, marking Cupid's bow peak, and then the trough, measuring this. It's usually around 3 to 4 millimeters, but this depends upon the patient's anatomy. And then I mark the medial Cupid's bow peak, from which the rotation flap is drawn, and the C flap, which extends intranasally from this point as well. The mucosal flap is drawn with a little concavity, for the vermilion is thinner on the non-cleft side. And then, of course, the intranasal triangular wedge excision to narrow the nares. And then picking Nordhoff's point. Now, this is essential as it sets the height of the lip on the cleft side. So I use the markings from the oral commissure. I also use the length of the philtral column on the non-cleft side to determine this location. You want the vermilion to be the thickest, and also for there to be a robust white roll. You will see here I mark Nordhoff's point, but then I change the location. I change it to a more medial marking. Now, if you are in between two markings for Nordhoff's point, choose the medial marking, for you can always move this marking more lateral at the end of the surgery if you need more length, but you can't move it more medial. Here's the advancement flap, and then the mucosal flap, which has a convexity, for the vermilion is thicker on that side, and then the Z-plasty release of the upper lip frenulum. Remember, with the advancement flap on the cleft side, don't extend that beyond the alar base. Here are all the final markings. I will update you with her on-table results tomorrow, and as always, if you have any questions, leave them in the comments below.